All right, to all here who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar, or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. This video will be available for review after this journal club. The information contained in the video content represents the views and opinions of the presenters and does not necessarily represent the views or opinions of Releve Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by RSM or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. There we go. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have read or seen on the site. RSM hereby disclaims any and all liability to any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly from any use of the video content, which is provided as is and without warranties. For all athletic trainers who are intending to get live CEUs from the VOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customer care at gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. I am going to make one little caveat to that. We are working with a company to move our website. They're creating us a new website that's going to be hosted on a different hosting platform. And so as soon as that gets switched over and then updated, then we should be able to send out that email notification. So that, which means that there'll be some subtle differences when you look at our website to find the statement of credit and then future registrations, but I'm sure you guys will get the hang of it. If you have any other questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from our website tomorrow. Dr. Rolando Gonzalez is a Florida-based clinical sports psychiatrist, board certified in adult, child, and sports psychiatry, working with elite and professional athletes across multiple states through Lee Health and his private concierge practice. He serves as an assistant professor at the Florida State University College of Medicine and has extensive experience supporting athletes in the NBA, NHL, Major League Baseball, WWE, professional tennis and golf, and Division I collegiate sports. A founding member of the American Board of Sports and Performance Psychiatry, Dr. Gonzalez currently serves as Head of Education and Chief Medical Officer. His clinical expertise includes post-concussive psychiatric care, therapeutic use evaluations, injury-related mental health care, performance anxiety, and comprehensive psychiatric treatment. And he's going to be speaking today on ADHD management for athletes across the athletic spectrum. And I'll have you take it away.
Awesome. Hey, all. I'm Dr. Gonzalez, and thank you for the introduction, Dr. Henning. So yeah, I'm going to talk to you today about something that I tend to get referred to more often than not, which is ADHD evaluations and care for athletes. In the general population, meaning non-athletes, it's a fairly straightforward illness to manage. But once you kind of add in some of the kind of mimicking factors of sport, just the context, the timing, and also some of the regulatory issues, especially for like college and professional athletes, it tends to be a little bit more complicated than most psychiatrists are used to. So I'll take it away. And so the objectives are recognizing ADHD presentations in unique to athletic populations, differentiating ADHD from overlapping medical and psychiatric conditions or comorbidity, explaining the impact of ADHD on athletic performance, injury risk, training, but also regulatory considerations, including the therapeutic use exemption, which we'll spend a lot more time talking about towards the end, and then applying evidence-based interdisciplinary care in this sport and athletic space for ADHD. So general info on ADHD, which is attention deficit hyperactivity disorder, which I'm sure a lot of you have heard of and probably have seen. So the diagnosis of ADHD is primarily based on the DSM-5 criteria, which is essentially the gospel of psychiatrists. Up until 2013, there was different criteria for diagnosing this illness, and it's become a bit more flexible since that time. So what you're looking for is a core pattern of, inattentive and hyperactive symptoms. It needs to interfere with functioning. These are typically viewed as developmental illnesses, so they're not necessarily lifelong, but they sort of persist through childhood and the teenage years, sometimes into the adult years. They need to be present for at least 6 months fairly consistently. You need to see the symptoms present before the age of 12, and that leads to some complications, especially for people that are presenting in their adult years. The settings, it can't just be in one situation, it needs to be in multiple settings, which is, again, can be really challenging, especially for adults. You need to be able to prove that there's clear clinical impairment and dysfunction, and it cannot be explained by another mental but also medical condition. And the examples provided were anxiety, depression, and trauma and substance use. Interestingly enough, the amount of symptoms required to diagnose it for a teenager versus an adult is one symptom different. And you can have a predominantly inattentive or hyperactive or combined presentation. So a lot of folks will say, I don't have ADHD, I have ADD. And I try to explain to them, well, this is the criteria, but I agree with you. So the symptoms of ADHD, and these are based off the criteria in the DSM-5. Understand that, most people are not going to present like the book, and you need to, be able to ask questions with the understanding of different contexts and the age of the person that's speaking with you. And we'll go through that in the sport context here shortly. But in general, for the inattentive symptoms, which, will be persistent throughout the lifetime, if you're going to see any symptom for an adult, it's primarily going to be the inattentive type. They tend to make a lot of careless mistakes, typically because they'll breeze through things or try to rush through activities, difficulty stay on task. In conversation, you might notice that they have a hard time following through, and the terminology they use is spacing out, but, kind of looking around, jumping topics. You feel like you have to interrupt them at times just to kind of bring them back to the topic at hand. Or they might just make a response of something that's totally irrelevant, which is somewhat comical, but very frustrating over time. They struggle to follow through with instructions, and they're very, disorganized. And so that's a really interesting thing where you might ask them a little bit about how they go about determining or keeping their day together. Do they have calendars? Like, what does their book bag look like? Who are they depending on to keep getting them from A to B throughout the day? This is an interesting one. Avoiding dislikes or reluctant to engage in tasks with sustained mental effort. So that there's a flip side to that, where actually a lot of people with ADHD can actually hyper-focus and have a hard time getting away from the things that they prefer. So I oftentimes teach folks that ADHD is not necessarily an inability to focus at all, but it's a difficulty with regulating attention and focus. And so that's why you might notice, especially with kids, that they have a hard time getting off of screens, even more so than most. They're easily distracted. They lose items and are very forgetful. So for an athlete, that might look like forgetting equipment, but it can be really frustrating when you're telling someone to do something multiple times over. The hyperactive and impulsive symptoms, it's pretty straightforward when you look at these symptoms as is. More difficult again with adults. The one that I often highlight is a run or climb inappropriately. I mean, that doesn't really apply to most adults, but what you might notice is they have a really difficult time, sitting through a meeting or sitting through a movie or even sitting through dinner. So there's finding excuses to get up and do different things. In general, hyperactive symptoms, the fidgeting, the running, the talkativeness, the being on the go, those kind of symptoms tend to subside as you get older. The impulsive stuff, like the difficulty waiting your turn, interrupting others, that can last, and you might tend to see that especially with some of the younger athletes. So, I mean, one really important thing to talk about with ADHD is why do we even care about this? Can't you just focus more? Can't you just exercise a little bit, manage your energy levels? And, for some people that does work, but for most people it doesn't. And unfortunately, they live lives of a lot of negative feedback, a lot of failure. And so what you can see, and the data supports this, is, progression into depression or anxiety, you know, a lot of substance use issues, but even like from a safety perspective, they tend to get into more car accidents, tend to get hurt more often. And so there's an issue with life satisfaction. So, you know, even if you're not thinking about like how well they're performing in their sport, try to think about them as like a whole person and how this is impacting them day to day. Okay. So general prevalence in the U.S., kind of the numbers are kind of staggering. You know, we were living by, you know, with children, it's more of like the 5 to maybe 10% range. That has changed in the last 5 years. Similarly, for adolescents, it's actually more than the child population. And you know, what I find is about half have problematic symptoms as they become adults. About a third will still have symptom criteria that meets an ADHD diagnosis in adulthood. And you know that it kind of reflects that in some of the numbers we found. Just keep in mind that the prevalence studies for the children and adolescents is actually later on than the stuff that we have for the adults, so it doesn't necessarily match up. But there's definitely a rising trend over the last 2 decades. Part of that is for what I've told you already, which is that the diagnostic criteria have expanded. I think the other part is that, you know, there's just a greater level of understanding as a whole, of awareness. But also, you know, we have a lot of virtual companies now that their sole focus is managing ADHD effectively. And I'm not making any sort of negative or political commentary here. It's just what's happening. So you're seeing more of it. And then comorbidity, I mean, you don't have to know these numbers specifically, just understand that, you know, with children and adults, comorbidity, meaning other medical and mental health illnesses, are present more often than not. It's very rare that I have a patient referred to me in any setting that just has ADHD. There's usually something else going on. And so for the most part, sleep disorders, anxiety, and ODD, which is oppositional defiance, which is essentially a cluster of symptoms where usually in children or younger teens, where they are fairly obstinate, they refuse tasks, they argue often, they get annoyed easily, they lose their temper quite easily. Okay, but just assume that there's probably more to the story than simply ADHD, which in itself is not very simple to manage. So ADHD in sport, and kind of why we're talking today. So the prevalence studies, you know, the elite and student athletes, this is primarily data from elite high school and college athletes, but for the most part, the 18 and older crowd. 7 to 9%, which is slightly higher than the 6.6 that I mentioned previously for the general population. And professional baseball, which they make their information public with regards to therapeutic use exemptions. If you're not familiar with a therapeutic use exemption, which is a TUE, that is basically an approval system in place to allow professional and Olympic athletes the opportunity to get treatment with banned substances in their sport that are, you know, proven or required by a medical professional. And so an example, and one of the more prevalent reasons to obtain a TUE is treatment of ADHD in sports. Okay, so in the 2017 to 2018 report, so they usually report this towards the end of the kind of off season, which is December. 8.4% of baseball players in the Major League Baseball required a TUE specifically for ADHD. So that was 90 players. The trend lately has been actually the opposite, where fewer are requiring it. But I will tell you from my clinical experience, that's not so much because it's not there, it's because the criteria and proof of getting it managed in that setting is very difficult. It's part of why I get a lot of my referrals from the MLB and MILB folks, okay? A lot of the other professional organizations do not provide this data, so we don't know a lot about what's present in the NBA or NHL, and you name it. And then I provided one study I found recently. It's an endurance athletes. This is all self-report, so it's via a scale that I'll talk about more later, where, you know, basically they're telling you they have the symptoms, but they're not actually diagnosed or evaluated by a clinical professional. But again, so just looking at the numbers for the adults, it's in general, it's accepted to be higher or probably about the same as the general population. So it's present, it's no different. For youth athletes, the data we have says it's about 4 to 8.1%, which is a little bit less, which I'm not really sure what to make of that other than that's the number you have, okay, but it's still present. So the things that we do know in general, that you're more likely to see ADHD in contact team sports. You're more likely to see it in males, okay? Just keep in mind that, you know, the prevalence is likely underestimated, in particular in the Major League Baseball population, because the therapeutic use exemption is only for folks that, A, were diagnosed by a clinician, primarily a psychiatrist, which most people don't have access to, and the people that are the athletes that are actually on a stimulant medication. Okay, so that's not capturing the folks that are diagnosed that are on a non-stimulant, which you can do, or doing therapy, or simply have elected not to get treatment. Okay. There's also a tendency to underreport for a variety of reasons, and one of the major reasons is stigma, right? So accepting or acknowledging that I have this illness, you know, because maybe it's a sign of weakness, maybe it'll give somebody a competitive advantage over me, you know, maybe a team won't sign me, or you know, give me a scholarship because they're concerned of how that's going to impact my performance. Okay. So signs of ADHD in sports, this is obviously not comprehensive, but these are examples that I tend to see more in my practice. Okay. So, you know, with time management and organization that they struggle with, you're going to notice that these folks tend to be more likely to be late to meetings or film review. They need a lot more help managing their schedule. Now, this isn't as problematic for a youth athlete, right? It's not as problematic for a high school athlete that has a parent or a stronger support system in place to kind of help them get from A to B. But as you progress to more of the elite kind of, you know, Division I, Olympic, professional sports, where there's a lot more going on, you're going to see more of this, okay? And I'll use the example of, you know, it's February now, the baseball players just reported for spring training. And then I'll start getting a lot of referrals sometime in March and April about an athlete, so-and-so has been late to a lot of meetings, they're not focusing as well, you know, we're having some problems with them. We'd love to evaluate them for ADHD. And a lot of times it's simply that they have never been responsible for being in meetings to that level. They've had a parent to get them through, or they're simply not understanding the importance of going to these meetings that they've never been exposed to in their lifetime. Okay. You know, they'll struggle with attention span and conversation, which might play out as, you know, especially if you're athletic trainers, you're giving them some instructions and they're not following through, or you're kind of going through a train of questions with them and they're not following the path of questions. Maybe the answers are irrelevant or they're kind of falling off. Okay. They might have difficulty waiting their turn in drills. And this can be problematic because sometimes that can frustrate some of their teammates and some of the coaches. You know, one thing you'll see, and this is not a symptom of the illness itself, but is highly prevalent, is emotion dysregulation. So they have quicker emotional reactions. So there's an interplay here between, you know, poor impulse control and these bigger emotional reactions where you might see them more likely to get more penalties, you know, more problems with umpires and referees, okay, or simply some of the teammates and staff where they're arguing a lot more often, okay. They might be more likely to interrupt others, take unnecessary risks. So outside of sport, you know, that could mean they're, you know, they're speeding, you know, just doing things that you really would appreciate them not to be doing, just kind of dangerous behaviors, but in a persistent way, okay. And then lastly, and this is kind of the classic kind of high school athlete, they're forgetting or losing their equipment. But I've seen this even in professional athletes where it's like highly publicized, and I've worked with athletes, and this is a symptom that we picked up on as part of our evaluation process. So we'll talk a little bit more about it in the next slide, but there are ways to help tease this out effectively. Just keep in mind that the whole list of symptoms that I mentioned previously, the DSM-5 criteria symptoms, can also present that way in a classic situation, okay? So the challenges of recognizing ADHD in athletes is, you know, oftentimes the symptoms could be masked by their performance and engagement in sport. So keep in mind that physical exercise, primarily cardiovascular exercise, can actually help mitigate and manage inattention, hyperactivity, and impulse control. Like, it's an actual form of treatment that has a lot of evidence that's effective, okay? So in competition, it's probably going to be less obvious of some of these problematic symptoms and behaviors. Okay. Athletes are attracted to sport due to the symptoms. So, sometimes we'll say that these are superpowers for them because they can hyper focus. They tend to be more spontaneous. They're more creative. Impulsivity, like poor impulse control, right? You could call it poor impulse control in the school setting or maybe sitting through a meeting, but like if you're more likely to react in an effective way, use the example of, being a shortstop in baseball or a point guard in basketball, like it's advantageous to be quicker and kind of how you're doing things. So, they might find over the years, like, this is great for me. This is working for me. I feel good when I do this. I get a lot of positive feedback. So you're probably less likely to see these kind of issues pop up in competition. Where might it pop up? Well, I mentioned before impulsivity and competition, they might get in trouble more often, more penalties, okay? But you're really going to pay more attention to training, practice, meetings, the more mundane, kind of monotonous, less reward-based activities in sports. And for you, especially for athletic trainers, I think that you're going to be the ones that are going to see this more often because a lot of what you're doing is a requirement, right? It's not necessarily something that they come into and they say, I'm looking forward to doing this today. I know they're not looking forward to seeing me in the office. They're coming to see me because they're having a problem, okay? The other thing is they might fail to follow through with your meetings. They oftentimes will forget, and you're catching yourself reminding them often of where they need to be and why, okay? So I think it's incredibly important to ask them about life outside of sport, okay? Ask the coaches and staff, like, how's it going with them making it to their meetings? Like, what are some of their practice habits? Are you finding that there's a lot of incongruence between performance and practice and the actual game? Like, how frustrating is it to work with them? The organization itself, like, have they become problematic? Who's reaching out to you about them? In scholastics, this might not be relevant in the professional world, but it's definitely worth asking about, with parents and their support systems, like, hey, how were they as a student? Can you kind of tell me about their reactions, interactions with teachers, their work ethic, and those kind of things? And then in personal life, talking to their partners, talking to their friends, talking to parents about, how much do these folks rely on them to get through the day? Okay, but it's really important to talk to the support team, the support staff, talk to the athlete about life outside of the sport, because that's where you're going to get most of your data. And that's where most of the problems arise. So I'm emphasizing this, okay? Most important to ask about signs and symptoms outside of competition. Incredibly important. So differential diagnoses. In the medical world, you know this as, other reasons why these symptoms might be present, other illnesses that might be causing it. So I didn't use ChatGPT or AI for a lot, but I most certainly used it for this, and it was awesome. So I really appreciate that. I'm getting used to it. But here's just an example of a lot of different ailments or kind of symptom clusters that can present as or look like ADHD, okay? And I know a lot of you are really interested in concussion. So I'll kind of give you a glimmer of that here as it relates to ADHD. So ADHD or symptoms of concussion or post-concussive syndrome. The complications here is that they share a couple of features. A lot of issues with memory impairment, primarily short-term memory, okay? Poor concentration and attention span, you're gonna see that in both for a lot. Mood lability, meaning fluctuations in emotions. They can be really tearful, they can lose their temper often. Unfortunately, the relationship between ADHD and concussion is that, ADHD, the illness itself, tends to increase concussion risk. Like I mentioned before, these folks can be risk takers. They can react more quickly. They can be inattentive. You can imagine how problematic that might be in a sport like football or, goodness, I mean, we're watching the Olympics right now, downhill skiing, the luge. I mean, incredibly dangerous if you're not staying on task, okay? And unfortunately, ADHD itself can delay concussion recovery. There's a couple of different explanations for that, but in general, just accept that it makes it more of a challenge overall, okay? So how do you differentiate it? Well, I think that the most important thing there is onset. Like I mentioned before, ADHD is for the most part a lifelong illness, and you're gonna see patterns of struggle with those symptoms as a child, as a teen, especially if they're an adult. You're gonna be able to pick up that pattern throughout the lifespan, okay? So if it tends to have started, right around or after a variety of head injuries, or you suspect that they've had symptoms of concussion, and these symptoms of inattention and impulse control have seemed to pop up after that fact, worth investigating if this is concussion or not. Recovery trajectory, if we know that there was an actual concussion or a head injury, you would expect that these symptoms would improve over the span of 2 to 4 weeks or the next few months. Okay, I'm well aware that some folks that have had multiple concussions or very severe ones can have these symptoms for a very long time. And we might not actually be able to differentiate, if this is a core ADHD illness versus concussion induced. But at that point, you're treating what you're treating anyway, so, it's not necessarily as relevant. Okay. Now, I know this is not always available depending on the level of performance that you're dealing with, but if you know going into the season that an athlete has ADHD, it would be wise to get some impact or SCAT2, SCAT6 testing done at the beginning of the season, because there's going to be impairments of this for folks with ADHD. So it's going to be important to be able to compare the before and after with that. Okay. So those are ways to do it. And of course, you can always refer someone to a neurologist or psychiatrist to help tease that out. But even then, it's very difficult. So other things you might see, sleep changes or disordered behaviors. It's very common for most people to have problems with sleep, especially college athletes and professionals. Just keep in mind that their schedules are wild, and most people need about 7 to 9 hours of sleep. So it might be simply worthwhile asking how many hours of sleep they're getting a night. But sleep restriction itself, even within 1 to 2 days, can look a lot like ADHD. Okay. I suspect many of you, like myself, have probably pulled a few all-nighters, and I want you to just to think about that experience. You're probably really jittery, maybe a little labile, a little bit impulsive, and I'm sure it was probably hard to stay on task as you're trying to take that exam that you decided was a good idea to stay up all night for. Probably worked once or twice and then failed miserably. Not speaking by experience. Insomnia, which is highly prevalent in ADHD, can look a lot like ADHD. Okay. Obstructive sleep apnea, which can happen in kids too, is worth screening for, because again, that can look like it. And just screening for these illnesses. All right. There's a couple of seizure disorders, including absence and frontal lobe epilepsy for certain kind of periods that can look a lot like it as well. Something that's worth asking about is, a staring spell versus zoning out. Okay, for the most part, in epilepsy, you're not going to be able to kind of capture the attention of somebody having an episode. So if it's a kind of succinct period of time, like, were you able to get them out of it? Okay. Was it brought on by a period of stress, like bright light or intense emotional reaction? Because if it was, less likely to be more so related to ADHD and more so seizure-like. Okay. There's a variety of vitamin deficiencies that might be causing this. Zinc deficiencies, vitamin D deficiencies, iron deficiencies, a variety of others can look a lot like some of the inattentive symptoms of ADHD and even some impulse control problems. Thyroid dysfunction, so hypo and hyperthyroidism, anemia, all mimickers worth investigating if you're not really sure what's going on. So I've listed a variety of psychiatric disorders here. Just understand that, the DSM-5 criteria for depressive anxiety disorders includes impaired concentration. So it can look like that. For me, I know to ask a lot about different symptoms, but for you in your setting, it might be worthwhile having the PHQ-9 screener, GAD7, scared, just a variety of screeners for anxiety and depressive symptoms on hand to help tease that out in a pinch. For bipolar disorder, which is characterized by episodes of mania, the overlap there is that they can be rather impulsive and very high energy, very talkative and risk-taking, but for a very clear period of time, which is about 4 to 7 days. It's just an abrupt shift from their typical behaviors. I like to ask a lot about sleep changes in that period of time and just kind of what they're like most of the time, and for these kind of patients and athletes, you're going to know from the people around them, it's a drastic shift from what you're used to. Okay. Psychotic disorders, there's a period of time, as they develop the illness, usually characterized by hallucinations and delusions, called the prodrome, where you start seeing them decline in attention, short-term memory, organizational skills. So just be aware that that exists, okay? For trauma-related stressor disorders, PTSD, they might be preoccupied by a traumatic reminder that might look like inattention. They might be, very restless and edgy, which might look like hyperactivity or restlessness, simply because they have ADHD. I have a variety of other psychiatric or kind of school-related illnesses here. I just wanted you to know that they exist. In the interest of time, I just want to highlight eating disorders. For folks that have anorexia that are malnourished over time, they actually legitimately have cognitive impairments and can't focus as well, have memory-related issues, okay? Autism, a lot of folks assume that they know what that looks like, but in general, most folks with autism are not very obvious. They tend to hyper-focus and are very rigid around transitions, so that might look like they have a hard time focusing, or they're just like really struggling to get through tasks. You might want to ask a little bit about some of their social life and how they relate to peers, but I don't expect you to be able to figure that out within your very brief interactions with some of these athletes. Substance use disorders, obviously an issue, highly comorbid. Worth asking about, but it's definitely useful to have urine drug screens available. A variety of substances, while intoxicated, can look like ADHD, and a variety of them, while in withdrawal, can look like it. Most problematic right now is cannabis use or THC utilization, just because of the high potency. Some of the laxness around, kind of screening for it in the sport population, and just the fact that it's recreationally used in many states now. So it just makes it a little bit more difficult. So, just context by itself with athletes, just keep in mind that burnout, overtraining, performance failure, acculturation, being in a new country, not really knowing the language as well, major life transitions, which could simply be switching a position or switching one level to the next. All of these can contribute to, essentially cognitive overload and stress that's really impairing their ability to stay on task effectively, manage your time, and just kind of stay engaged. That's going to look a lot like it. So just be comfortable asking, like, has anything changed for you? Or try to think about them in the scope of their lives right now. Like, this is so drastically different. Okay, so that all can look like it. Other simple things, making sure that we're screening for hearing testing and vision testing, because by itself, those can look like it as well. And they're easily missed, because we assume that somebody else did the evaluation, and maybe they did, but it's been a few years. Okay, so screening and diagnosis. It's hilarious because I gave this one slide, right? But we've been talking about screening and kind of how we're doing a diagnostic evaluation the whole time, so keep that in mind. All right, so some of the useful screening tools that I like to use, and a lot of medical professionals, you'll see them utilize the Vanderbilt, which is free and available online. Primarily a screener used for teachers and parents, so it's good for collateral information. It'll cover all the symptom criteria and then some. So, having that on hand or being comfortable asking like a parent or maybe somebody on the staff to use that might be good. The adult ADHD self-report scale, which is called the ASRS, is very effective and used for screening in the adult populations 18 and older. So you might want to have that on hand. Connors rating scales, they have them for, kids, they have them for young adults, they have them for teachers, they have them for parents. So it's across the board. The Wonder Utah scale I like to use a lot just because it asks a lot about retrospective child symptoms. So I'll give this to an adult, and there's a section that asks a lot about current symptoms, and then it'll review, some of the issues they may or may not have had as children or teens. It also has like a lot of false positive questions that might help screen out some of the things people think you need to think about or think you want to hear when you're trying to screen them for ADHD. So some diagnostic tools that are very useful, the diagnostic interview for ADHD in adults, it's called the DIVA 2. There are many. I like this one because A, it's free, and B, the USOPC, the Olympics, they like to ask for it. WADA likes to ask for it, so international competitors. Major League Baseball will accept it as part of the evaluation. I've used it for some professional tennis and hockey players. So it kind of covers your bases there. It's additive. The Barkley Functional Impairment Scale isn't necessarily diagnostic, but it does help you to tease out where the illness or symptoms are getting in the way. All right, so those are two tools that I will utilize in my evaluation specifically for athletes where I have to do a therapeutic use exemption evaluation. I'm not always using it, but if it's a young adult coming into my practice saying, hey, I'm noticing I'm having these symptoms and it wasn't clearly obvious as a child or a teen, I definitely want to beef up my evaluation. Okay. Now, for folks that have a lot of money and they can just do this, they have access, they have time because these evaluations take a few months to get done, or they've been seen by a medical professional and the medical professional is not clearly able to rule out ADHD or clearly define it because the person has a variety of other mental health diagnoses like anxiety or depression, recent concussion that's kind of clouding the picture. You might want to refer them for neuropsychological testing specifically for symptoms relating to ADHD. Okay. The terminology around this kind of testing varies. Some people might call it psychological testing, some might call it psychoeducational testing. I would just be really specific in asking, have you had testing by a psychologist that's trained in getting an evaluation done for ADHD? Okay, very useful. It can be a supplement, but in general, the clinical evaluation by itself is all you need. Okay, so if you know somebody, you have somebody you can refer to that can get that done, tends to be a little bit quicker and more cost effective. But hey, if you want to do it all, do it all. And I have a picture here of the Diva 2. It's just an example of one of the pages. So I like it because I can use it. I can have some commentary by the athlete, their family member or staff member that I can kind of include in different font coloring, and it's generally accepted to be useful. So treatment, just kind of think about this in in large buckets. You have your non-psychopharmacologic, right? So your non-meds, and then you have your med approach. Okay. We're going to try to review some of the athlete-specific considerations here because it does matter, in the sporting context, how you're approaching this illness. We'll talk a little bit about the therapeutic use exemption and just, highlighting the importance of collaboration here. I have some research studies that I've highlighted. It might not be in the best interest of our time going through them, but you'll have access to them later on if you want to take a look at some of the major findings of them. So behavioral interventions, I would think about this kind of starting from the behavioral management, cognitive training as more of tools you're going to use for the younger kids, school age populations like 12 and younger. Parent training programs can be really effective because they're trying to institute or teach kind of evenness and response by parents and expectations. Okay, kind of having a level tone, being assertive and kind of what you're looking for. Having a regimented plan for organizational skills, reinforcement structure, for rewards for doing what's being asked effectively, but just kind of knowing how to talk to somebody with ADHD, not losing your temper because they're not listening to you, trying to avoid giving them multi-step tasks, maybe utilizing visual schedules and boards to help them understand the next steps of the day. All right. The cognitive training tools are really adjuncts in treatment. They don't have great evidence and support for managing ADHD, but essentially think of these as like attention training tools. A lot of these are computerized and kind of fun. I like to use cognitive behavioral therapy and refer a lot of the adults and athletes for this just because it gives them a sense of agency. It's well structured, but it does parallel a lot of some of the parent training programs. Okay, and there's decent evidence there, but I would focus, when you're thinking about this, it's a little bit more about kind of managing your lives, like organizational skills, emotion regulation, and it's also, focusing a lot on some of the, comorbid anxiety, depressive symptoms that these folks deal with. Okay, so standalone, it can be effective. In general, not as effective as the medication alone. So you're usually kind of doing a combination. I highlighted acceptance and commitment therapy just because it's a kind of more fluid version of CBT. Just, be familiar with that term. It's more mindfulness based, and mindfulness in a lot of ways can help people slow down and be more attentive. Okay. EndeavorRx, CogMed, these are kind of newer prescribed digital therapeutics. They, essentially infuse a lot of what I've already talked about. There's some decent evidence for them right now, but the longitudinal data isn't quite there yet. But if you have access, you can afford it, it is worth a try, especially for folks that do not want to try the medications or don't have the time for doing traditional therapy. So for you, the coaching staff, for some of the positional coaches, for the families, here are some strategies or kind of methods I would suggest thinking about. Very useful to have visual schedules. A lot of folks with ADHD either struggle with kind of auditory processing or memory, and so it's useful to show them, kind of give them a frame of reference. Especially if you're working with like younger kids or teens, kind of acting out what you want them to do, kind of showing them physically. All right, maybe having them act it back out to you, explain it back. Limit those multi-phase instructions. Kind of give them one task at a time, and then have them come back and show you, hey, I know how to do this, or it's completed. Okay. Or working with them on having some sort of application note on their phone, some sort of notes that they can write down on a piece of paper that shows they've completed each task subsequently. Okay. But you really want to check in with them and make sure that they're doing step by step, because they tend to get lost after a couple. Okay. And just don't confuse that with refusal. I think a lot of them want to complete it. They simply forget or get distracted. Now, emotion regulation training, this more so relates to folks that have like performance psychologists or like certified mental performance consultants on board that can help do it. I like to make sure that the tasks are concrete and very clear. Immediate feedback is very useful, especially for younger kids. You want to give them a lot of positive feedback as much as possible, because they are prone to being sensitive to negative feedback, and they get it a lot. So it makes sense that they would feel that way. Okay. So again, thinking about them as a whole person, they probably don't hear a lot of positives about their behaviors in school. So just trying to kind of help them feel what we all get to feel when we do things well. All right. And again, like I said before, the repeat back method, just having them teach it back to you. Okay. That's a good teaching tool for anybody, but in particular, you want to make sure that they've registered the information. So there are other strategies in place. I just find these to be very useful. Oh, and I failed to mention with school-based interventions, there's a 504 plan, the individualized educational plans, but there's, basically these are a variety of strategies and tools in place that the school can help formulate to support them throughout the day. In the kind of school age, middle school, high school years, it's more formalized for folks that are in college. For the most part, it's simply getting accommodations for taking tests and exams. So just, being able to help your athlete know that, hey, you do have access to these things, but you need to tell somebody you have the illness for you to get access. Okay. Sorry for skipping over that. That's pretty important. So the psychopharmacologic approach, again, trying to keep this simple. You have stimulants, so Ritalin, Adderall, you know what these are, you've heard of them, Focalin, Concerta, Vyvanse, you name it. They all do essentially the same thing, and we'll talk more about this in a minute. So that's one option. This tends to be the most popular. Second major category that has good evidence and data are the non-stimulants. So these are the selective norepinephrine reuptake inhibitors, so atomoxetine, which is Strattera, and then Qelbree, which is a newer med that does a similar job, and then your alpha-2 adrenergic agonists, which are clonidine and guanfacine. So these are blood pressure meds that are effective in treating ADHD too. Off-label, meaning there isn't an FDA approval for these. They're kind of looked at as third line and maybe even fourth line medications. Stuff that I'm going to use more often, primarily because these also treat other illnesses that I deal with a lot. Bupropion, which is Wellbutrin, which is an antidepressant that manipulates a protein or a neurotransmitter called dopamine that is highly responsible for struggles with inattention, distraction, poor impulse control, and hyperactivity. So sometimes it can be useful. Primary side effects with that medication to be worried about are that it does lower the seizure threshold. So, for somebody that's had a seizure illness in the past, you definitely don't want to give it to them. For somebody that's actively struggling with like alcohol abuse or an eating disorder, you might want to avoid it as well. But useful if somebody has depression and very mild ADHD, definitely worth considering. Nortriptyline is a tricyclic antidepressant, which is kind of an old school antidepressant. I will use this in some patient populations if I failed a lot of the other options. problem with this medication is the side effect profile for it is very broad and uncomfortable and kind of annoying, can be sedating, can cause constipation. So, you know, you're really not really thinking that'd be useful for like an athlete that's going to kind of try to react very quickly, has a very kind of limited schedule. You probably don't want them sedated and, you know, less oriented to what they need to. Modafinil is actually also banned, you know, like the stimulants in the professional sport world, and just isn't as effective. So I'm not really seeing the reason for utilizing that, but that is approved as a treatment for narcolepsy. So you might see that, but it's an activating agent. It does hit some of the same pathways. So the norepinephrine reuptake inhibitors, the Strateras and the Qelbreys, you know, they have a moderate effect size. Essentially what that means is they're mostly helpful. You know, they work in about 50 to 60% of folks that just take the medication for ADHD. But unfortunately, that is not as effective as stimulants. So they're not as useful on average. Okay, they take about 4 to 6 weeks to take effect. Keep in mind that I don't just start the dose you need for it. You know, most people have to kind of build it up because side effects can be problematic if you just start them at the weight-based dose. Okay, and so those side effects in general are like nausea, you know, stomach upset, you know, sometimes headaches. You can have some sleep disruption. It can have some mild increases in blood pressure. The more severe can actually cause some sort of some form of liver impairment. That's very rare. I don't typically investigate that unless there's some symptoms related. But on the positive, it is a 24-hour medication coverage. Okay, it covers them throughout the day. It is not prohibited in WADA, so you don't need a therapeutic use exemption. So it is easier to get access to. But unfortunately, there's not as much data for people that are like the kind of younger kids, younger than, you know, 12 or 13-year-olds. So I don't tend to use it in those populations as much. Think about it more for teens and adults. Okay. Alpha-2 agonists tend to be a more preferred option for the younger kids. Unfortunately, one of the main side effects, and that's going to be a rate limiting step for a lot of athletes, is that it can cause sedation and dizziness. Usually takes about a week or two to get used to that symptom. Takes about 2 to 3 weeks to kick in and be effective. In general, better for hyperactivity, impulse control. Again, coming back to the kind of what I mentioned before, mostly, you know, you're going to see more of those symptoms for kids and teens. Okay, I do like to use it though in the evening. It is kind of a good add-on for people that are taking stimulant medications earlier in the day. So, stimulant medications. These are going to be the most commonly prescribed. They're the most effective. You have methylphenidate and you have amphetamine. Essentially, all the names you know and trade names and such kind of branch off of one of these two medications. They both reduce the reuptake of dopamine and norepinephrine, which are both responsible for managing symptoms of ADHD. Okay. The major difference is that the amphetamines actually increase the release of these two neurotransmitters. So theoretically, it's a more potent medication, meaning you need lower doses to get the same effect as methylphenidate. In practice, it doesn't mean a whole lot different, except there's some studies out there that show that folks on ADHD medications like Ritalin or Focalin over time tend to need higher doses for effect, whereas you're going to see that a little bit less often with the amphetamines, but that's not necessarily grossly true. I'm just kind of giving you some of the data there. There are a few studies that show that some of the amphetamines are more effective than the methylphenidate options for folks, like for adults. So that's interesting. Do we know why that is? I kind of told you, but it's not really as clear. There are different formulations, so ways to receive these medications. So capsules, tablets, liquids, chewables, patches for both categories. You know, keep in mind that most of the folks that get diagnosed and treated for this are kids. A lot of kids have not swallowed pills, so we have to be very creative in that clinical space. All right. You have your short actings and your long actings. A short acting stimulant tends to take effect within 15 to 30 minutes, last anywhere from 3 to 6 hours. Okay. The long actings take anywhere from 30 to 45 minutes to kick in, can last anywhere from 6 to 12 hours. You know, this is all theoretical. Kids tend to have faster metabolism, so sometimes you're, you know, dosing them twice a day with a long acting. It's really hard to tell and predict, so that's why a lot of us prescribers will start low and just kind of build up the dose. That's your safest bet. I highlight here that, there's a methylphenidate medication called Jornay that, interestingly enough, you will give before bed and will magically kick in when the person wakes up in the morning. I find that to be incredibly fascinating. I do use it in practice. It does mostly work that way. The interesting side effect is some people might wake up an hour or two earlier. But think about this as a treatment that is useful for somebody that really needs to get up early in the morning to get going, to get dressed, get their meals in place. For an athlete, think about your runners, your swimmers that tend to have their practices early in the morning. Might be more useful with them. So here are two really useful visual tools that are free, and I've given you kind of where you can receive that or where you can look it up. But just a nice visual of the different medications. So this page is dedicated to the methylphenidate options, gives you a visual of some of the pills and capsules that somebody might be receiving. It does give a lot of information about like what's approved at what age. There's just for you to understand, there's so many different versions of this. And I don't get married to one or the other. Just understand that there's different names and ways that people can bring this up. Okay. This picture's not as great, but it's kind of the same concept. All right. Interestingly enough, there are, I would say, 3 or 4 novel kind of medication options coming down the pipeline. There's some studies coming up. I don't know enough about them right now to tell you about it. The studies have not been shown yet to be effective and safe in a controlled setting, so we will find out soon, but I'm excited to learn more about it. Let's see, timing-wise, okay. So effectiveness, about, the first time you try a stimulant, it's about a 70 to 80% chance it's gonna be effective, okay? If that doesn't work, you try a second one, that number goes about 85 to 90%. So they tend to be useful. If you're not getting effectiveness out of these medications after a couple of different trials, probably need to revisit your comorbidity, other illnesses that might be causing it, kind of rescreen for some of the other kind of the differential that I mentioned before. I mentioned they're more effective than non-stimulants. The quick action, a reason why a lot of people like to use them is you don't have to take them every day. They tend to be effective within the day you use them, and they're, essentially kind of the effects are out by, by the end of the day. So that's nice. It's useful. A lot of, people in school will use them mainly on school days and not at all. I've mentioned before that, it's not necessarily as much of an issue when people are like actively performing, their physical task or their sport. So, what you'll see most of the time is, especially for like a school athlete, especially like the teens and college athletes, they'll take it during the school day when they need it, and then they don't use any medications for the afternoon or evening when they have competition. And that's perfectly acceptable for the most part. And then substance abuse. So this is controversial. What people always say to me, or not always, but mostly say to me is, I don't want to get addicted. I'm worried that it's going to increase my chance of abuse of illicit substances. And so thus far, what we know is the opposite, short-term and long-term. Okay. In general, if you effectively manage ADHD, which includes poor impulse control and hyperfocus, which might include issues around hyperfocusing on drugs, poor impulse control around substances, okay? So regulating that dopamine. You're less likely to see it acutely and long-term if treated effectively. So just keep that in mind. That's not a reason not to do it. If you don't want to take the medication because you don't want to deal with a side effect, you don't want to deal with the regulatory body of professional or elite sport, like I totally understand, but if you're fearful of that, that's not a legitimate reason for not taking the medication. At least as per the evidence. Google, I can't argue with Google, that's a losing battle. So the side effects to be aware of, very likely to lower appetite, it can delay sleep onset. What you might see with the mood is that while on it, it might make them a little bit more edgy. Not really a mood symptom, but they can make them more anxious at times. Where you see it more so is where the medications wear off, people can tend to be a little bit more emotionally labile, meaning more irritable, more likely to lose their temper. Not as big of a problem for adults, but you might see that more likely with kids. So, ask about that, like the late afternoon, early evening, how are they doing emotionally? Because if they're really struggling with that, it might be a clue to have them revisit the prescriber. What I tend to do with that is either I try something different altogether, or I'll add a short-acting medication that does a similar job to kind of help supplement and bridge it. I look at it as like a withdrawal symptom. Not dangerous, but it can be obviously quite annoying. Mild increases in blood pressure. So, as a clinician, what we like to do is we like to have vitals present before starting it and, throughout the course of treatment. Now, severe concerns, sudden cardiac death, arrhythmias. There is a very, very low but real chance of these things happening. So what we need to do is ask about, family history of severe cardiac illness, in particular for folks that are younger than 50, okay? Ask about personal clinical history of any sort of arrhythmias or murmurs or any sort of cardiac history at all. Like if I see one note from cardiology, like I'm all over that. And having a low threshold for stopping and holding the meds, talking to a cardiology specialist if we have any concerns, okay? But, in general, as a clinician, if I'm not hearing any of that in my history, you're not gathering any symptoms, there's no significant family history related to it, I'm not doing, standard EKGs and those kind of things, all right? That's not absolutely necessary. Just keep in mind it can be problematic for some. So this is what is more so relevant for you guys, appetite suppression in sport. So it can be a huge issue for, let's kind of think of, weight-based sports that it matters. MMA, boxing, right? They need to make some form of weight up or down. It can be challenging to manage that on a stimulant. On one side of it, because your appetite's going to be suppressed throughout the day, right? So you're going to be less likely to eat lunch. It's hard to gain weight. On the flip side, some people will have kind of a rebound appetite in the evenings and afternoons, which might look a little bit like binge eating, and they might struggle a little bit to make healthy food choices. So that can be problematic. There is a worry that, stimulant medications might negatively contribute to relative energy deficiency in sports, so RED-S. We don't know yet. There's a study ongoing right now. We might find out sometime in May or June a little bit more about that. But the general idea here is that the medications might, contribute to malnourishment and lower energy levels because of what I just mentioned with their ability to eat the right amount of food. Okay. And then, of course, you would worry about somebody with anorexia or some sort of binge eating, bulimia, and how that contributes to that already present eating disordered illness. Okay, so obviously you need to screen for that. Keep in mind that eating disorders are much more prevalent in sport. That's true. That's a fact. With sleep, I mentioned before, that's already problematic. There's going to be delayed sleep onset. So just keep an eye out for when they're receiving their medications. If somebody's taking Concerta, which lasts about 8 hours, and they're taking it at like 2 p.m., you might want to talk to them about, what's an appropriate time for that, or maybe have them revisit their prescribing clinician about like the best time to use that medication. The cardiac concerns and heat illness, these kind of run hand in hand. With heat illness, stimulant medications in particular do a couple of things. They're vasoconstrictive, right? So that contributes to body heat. They do raise, your blood pressure a little bit, your respiratory rate, okay? They raise your heart rate a little bit, all contributing to body temperature. Also, which is really fascinating, some stimulants can actually lower your perception of fatigue and effort required at higher temperatures. So it kind of makes you think like you're fine. So these three things together can put you at risk of dehydration and severe heat-related illness, like, that potentially could lead to stroke. So it's really important to make sure they're hydrating effectively on these medications. So that's why, collaboration, talking to you guys and making sure they're on it is vastly important. There's not a lot of data on this, the ADHD edge, but I mentioned before that, a lot of folks with ADHD are more spontaneous, creative, they can think better on their feet and react more quickly. And some find that on, particularly the stimulant medications, that kind of goes away a little bit. It's almost like they're kind of more blunted. And you can see that emotionally, but they don't have this like motion, they don't have their same range of emotions. People will say, I don't want to be a robot. And I think this is what they're referring to. But this can negatively impact performance. So I would argue that in ways, these medications are actually, problematic for performance. And I'll use an example or a couple of examples to maintain confidentiality of working with some really high-level tennis players who told me like, hey, I identify as very reactive and intense player, and they elected to not continue the meds because they felt that they were losing that with the treatment. So, they went more of the behavioral therapy non-stimulant route, which worked well enough. Okay, but keep that in mind, like that can happen. So stimulant medication in sport, just to highlight, it is really complicated. I get called a lot just to do these evaluations and help players and team and staff just navigate, what paperwork do you need? What documentation do you need? Okay. In the US, professional league stimulants are prohibited year round. So if they're getting drug tested in the middle of the off season, they could potentially screen positive. And if they don't have their therapeutic use exemption or any documentation to support that they have this illness, they could be suspended for however long the league likes to do that. And you know what it looks like in the news. It simply says they got pegged for, PEDs, right? Doesn't look great. In WADA, it's prohibited in competition only. So think of like Olympic athletes. So they could technically be on these treatments in the off season without getting screened for it. But in general, let's have the documentation on board. Let's make sure we're getting the therapeutic use exemptions done. We're doing it, yearly, making sure we got everything we need a few months in advance. I'm using some examples. It's more comprehensive than this, but here are just some of the governing bodies in the United States that require TUEs, especially in particular for ADHD. It varies though. Baseball is a great example. Like if you're on non-40 man versus the 40 man roster, there's different set of rules and requirements here. Different teams have a different process of going about it. A lot of times they require 2 different clinicians to do the evaluation. In the NFL and MLB in particular, they have certified clinicians that do the evaluation. They have their own separate training that you need to be able to find the person that can do it in time. Requires screening tool documentation, requires diagnostic tools in paper shown. Oftentimes they're going to want to see that you tried or at least considered non-stimulant options for treatment. So it's just a higher level of proof across the board. And it makes an otherwise pretty straightforward way to treat this illness quite complicated, challenging, and very stressful for some of the athletes and some of the staff. Okay, so I get a lot of phone calls, especially for MLB, starting in like April and May to get people in real quickly to get this done if we can. All right. Of note, MLB prohibits the use of short-acting stimulants, which is kind of challenging because our day is rather long. MLB players have really long days. A lot of athletes have incredibly long days that are not simply 8 to 12 hours. And so, stimulants are difficult because they're not going to cover you the whole time. So you have to be creative. And a lot of times I'm going to give them a short acting in the morning to kind of give them 4 hours, stretch out the next one for about 8, potentially even adding a short acting in the afternoon. So just understand that like it can be kind of like playing Tetris at times. So just understand that most TUE denials relate to poor documentation, just poor planning overall. All right. So let's see, it's 1:33. I'm just going to give Dr. Henney the opportunity to cut me off here. Or am I good to go? Let me see if there's anything on the chat.
Yes, I'm jumping. Where are we at in terms of closing?
How about this? Let me just cover 2 really important things and we'll get it done. A lot of this is just research that I really don't need to kind of read to you guys. I just wanted to have access to it. Cool?
Love it.
All right, awesome. So here's one study that you should read about how ADHD meds impact performance. Just keep in mind that underlying number, it's actually very small. Okay, here's some of the ways that might impact power output and strength. We know it to be true, but the data is actually not that thorough. So I kind of find that interesting. So why do we know that? So this was a study done in 2023, 2024 by the International Society for Sports Psychiatry, which I'm a member of. It basically did a survey of a bunch of prescribers like myself that, kind of prescribing preferences for ADHD in athletes at all levels. The findings were that stimulants are the preferred choice. Just understand that about 8 years prior, and for the most part, these are the same folks doing the study, the preference was for non-stimulants. And the kind of rationale for that shift was that, like, let's focus on what we know the evidence to support, right? The stimulants are more effective, and we'll deal with the regulatory burden as we go. And that was the kind of outcome of that. So here's some tips for evaluation. I kind of mentioned it: documentation, school records, talking to as many folks as you can. If you have the neuropsychological test available, or if you have access to it, it's useful and helpful, but you don't need it. All right. Just making sure you're documenting the diagnostic criteria very clearly. So symptoms, the age of onset, that you ruled out depression and anxiety and concussion, and how it's impairing are all very important. I've been in situations where I've either received a referral because some of this wasn't done and it was as simple as me documenting what we already knew effectively and it got covered, or me finding after doing a very thorough evaluation that I simply couldn't support it because I didn't have that information by way of all the information that I just talked about. So sometimes it's as simple as that. So interdisciplinary focus, just understand that you all are the first line here. I think that having some sort of standard screening procedure in place for ADHD specifically, because it's so comorbid and so hard to tease out, is useful, especially in the pre-participation physicals, post-season evals. But if you get an opportunity to spend time with them and they're mentioning concentration, focus, impulse control concerns, these don't take very long, okay? Just understand that there's a greater level of pressure to accurately diagnose, especially for the sports medicine doctors. So, as much data as you can come together with here is useful. Okay. Here are just some of the players involved and the folks that I would suggest having on board. I know it's a little bit of self-promotion, right? I do get some business out of this, but it would be good to at least know of a psychiatrist, neurologist, or psychologist that's comfortable with effectively diagnosing ADHD, especially in the adult population, especially with athletes that have some familiarity with sport, okay? And then for you folks, it might be a good idea to have some scheduled hydrations, even more so. Really make sure you're honing in on the protein calorie supplementation for folks that are especially on ADHD medications like Ritalin and Adderall, and potentially having nutritionists or dietitians on board to kind of help support them, okay? So here are some studies that are really interesting. Me basically telling you that, TUEs are not given very often in sport, and I kind of told you why. And so this is essentially undertreated in those populations, especially the Olympic and professional athletes, all right? In general, we somehow over and underdiagnose ADHD effectively. And I think a lot of it just has to do with lack of access, lack of understanding and experience in dealing with it, okay? Here are some of the tools you're going to be asked to use with therapeutic use exemptions. It changes for all of them. So yeah, cool to know, but doesn't apply to everything. So even myself, I've done a lot of them. I've done them for different governing bodies. I don't know all of them, and I have to ask, and I have to do a lot of reading to prepare for new ones at times. Okay, so it's prevalent, raw differential. There are unique presentations for athletes, and it's really good to have a great team on board to help you support them effectively. Okay, so you have my info at the end here. I am more than happy to help point you in the direction if you need it. Okay, thanks all.
Perfect. And I'll look and see. There was one question previously that I was able to get answered for you. But if people have questions, what I'll do, just for the sake of time, I'll have them reach out to you directly with those.
Sure.
And that also gives you, I know there was at one point, there was about 80 attendees. And again, nearly 100% of people here are athletic trainers. So hopefully for the athletic trainers who have attended today, this is a good resource for you. And you're able to, if you do have athletes that need that sports perspective on psychiatric care, can do that. And I do know for some of you guys too, there was a survey that had gone out after one of the recent journal clubs that we did, that was asking about persistent symptoms post-concussion. And so Dr. Gonzalez could also be a resource if you do have folks with persistent emotional attention symptoms that he already addressed in this presentation, but something along those lines. All right, well, thank you so much, Dr. Gonzalez, for speaking today and for providing us really good information here in terms of across the breadth of the sports and psychiatry intersection. We really appreciate it.
Yeah, thanks for having me. Thanks for your patience and time, everybody. I really appreciate it. You have my contact info. Just reach out. I'm happy to talk about this stuff for support if you need it, okay?
Awesome. Have a great day.
Bye all.